For this explainer, we're going to do something a little different. We're stepping right into the hot seat of a consulting surgical oral board exam. So I'll be your examiner, and I'll also be your candidate, walking you through the answers as we tackle a really tough case, a critically ill patient with severe ulcerative colitis. Let's see how it goes. All right, candidate, let's begin. You are the on-call surgical consultant. The ER is on the phone with a referral. Let's see how you handle this.
So you've got a 34-year-old with a known history of pancolitis who comes into the emergency department. She's got a fever of 38.8 Celsius, a heart rate of 125, and she's telling you she's had 10 to 12 episodes of severe, bloody diarrhea every day. What are your immediate concerns, and how are you going to proceed? Okay, so my response as a candidate. Thank you. This patient is, without a doubt, critically ill and possibly septic. My first thoughts are all about hemodynamic instability. She's losing a ton of volume, she's bleeding, and I'm also worried about an acute surgical abdomen, specifically a toxic megacolon or even a perforation. So my approach is pure ATLS, resuscitate and assess at the same time. I'd make sure she has 2 large bore IVs, and we start hitting her with aggressive fluid resuscitation, probably crystalloids. At the same time, I'm sending off a battery of urgent blood work, FBC, electrolytes, CRP, a lactate, and of course, a group and save. And I want blood products on standby, ready to go. While all that's happening, I'm doing a focused history and a physical exam, looking for any signs of peritonitis.
Good. You've kicked off the resuscitation. Now let's really sharpen this diagnosis. You've correctly identified that this patient is severely unwell, but I want you to be more precise. We need to accurately classify the severity of her condition. So, before we dig into this patient's specific workup, I want you to define the entire spectrum of severe ulcerative colitis for me. Tell me the framework you're using to classify just how sick these patients can get. Absolutely. So the spectrum really starts with what we call severe colitis, and this is mostly a clinical diagnosis. You're looking for those key symptoms: frequent bloody diarrhea, weight loss, obvious signs of volume depletion, fever, and often severe anemia from all that blood loss. The next level up in severity is fulminant colitis. Now, this has all the features we just talked about with severe colitis, but here's the critical difference. We're now seeing progressive symptoms of systemic toxicity. This patient isn't just sick, they are actively getting worse, even with our initial support.
Okay, so from there, we can diagnose toxic colitis. And this is when we add objective, measurable signs of a systemic inflammatory response to that picture of fulminant colitis. We're talking specific signs of toxicity, like a high fever, a really fast heart rate, and a sky-high white blood cell count, leukocytosis. And that brings us to the final, most life-threatening stage, toxic megacolon. This is both a clinical and a radiographic diagnosis. The patient has to meet all the criteria for toxic colitis, plus they have to have clear radiographic evidence that their colon is significantly dilated. This is a true surgical emergency. It's basically screaming that a perforation is imminent.
Radiographic evidence. What specific finding are you looking for on an abdominal X-ray? The key diagnostic finding is a transverse colon diameter greater than 8 centimeters on a plain abdominal film. When you see that, it tells you there's a profound loss of muscular tone in the colon, and the risk of perforation is incredibly high.
Excellent. Okay, let's get back to our patient. It's been 48 hours. She's had maximal medical therapy, IV fluids, IV steroids, broad-spectrum antibiotics, but she is not getting better. Her abdomen is even more distended, and she's still tachycardic and febrile. So let's talk about the indications for surgery.
Of course. The best way to think about the indications for surgery in UC is to split them into emergency and elective reasons. The emergency indications are pretty clear-cut: life-threatening hemorrhage, a full-blown toxic megacolon, or fulminant colitis that's failing medical therapy, which is exactly where our patient is right now. On the elective side, you're looking at things like intractability, basically a terrible quality of life even on meds, serious complications from those medications like long-term steroid use, or a high risk of cancer, which usually means finding dysplasia on a surveillance scope.
You mentioned neoplasia. What's the significance of finding a stricture in a patient with ulcerative colitis? That's a critical high yield point for any exam. Because UC is a mucosal disease, true inflammatory strictures are really rare. This leads to a fundamental rule in our field. Any stricture you find in a patient with ulcerative colitis is considered malignant until you prove it's not. The data actually suggests there's about a 24% risk of an underlying cancer, which makes it a very strong reason to operate.
Very good. So you've made the call. You're taking this critically ill patient to the operating room. Talk me through your definitive surgical plan. What is the operation of choice here in this emergency setting?
Right.
For this patient, who is unstable, septic, malnourished, and on high-dose steroids, the name of the game is damage control. So the procedure of choice is a total abdominal colectomy with an end ileostomy, period. It is absolutely crucial to state that a complex pelvic dissection or trying to do a primary restorative procedure, like a J-pouch, is completely contraindicated. The risk of a leak or overwhelming pelvic sepsis is just way too high. We do the life-saving operation now, and we can think about reconstruction months down the road when the patient is healthy and recovered.
Walk me through the key technical steps of this operation. Certainly. So first, we'll do a midline laparotomy to get good exposure and have a look around. Second, we fully mobilize the colon, all the way from the cecum to the sigmoid. Third, we ligate the main colonic blood vessels, the ilocolic, middle colic, and inferior mesenteric arteries, but we do it close to the bowel wall. This is to preserve the blood supply for any future pelvic surgery. Fourth, we transect the bowel at the rectosigmoid junction. Fifth, the end of the small bowel, the ileum, is brought out as a standard end ileostomy. And finally, number 6, we have to manage the rectal stump. We can either oversew it and leave it in the pelvis, that's a Hartmann's pouch, or bring it out to the skin as a mucus fistula.
Okay, the operation is done. The patient is in the ICU. What specific postoperative complications are you anticipating? What are you actively looking for?
In the immediate post-op period, my number one concern would be pelvic sepsis from a breakdown of that rectal stump. That requires aggressive management. Small bowel obstruction is also common after any big abdominal surgery. Looking longer term, we have to counsel patients about risks like sexual dysfunction or infertility, which are really tied to the second stage surgery, the proctectomy. Other potential issues are hemorrhage and stricture formation. And of course, way down the line, if they eventually get a pouch, we have to be ready to manage pouchitis.
Let's fast forward. The patient recovers well from her emergency operation. She now has an end ileostomy and a retained rectal stump. She comes to see you in your outpatient clinic for follow-up. What's your plan for her long-term surveillance, and what exactly are you looking for?
The biggest long-term risk in ulcerative colitis is developing colorectal cancer, which typically comes from flat dysplasia. So, rigorous surveillance of any bit of remaining colorectum is non-negotiable. For a patient with pancolitis, surveillance should start 8 years after their initial diagnosis. This means an annual scope, in her case, a flexible sigmoidoscopy of the rectal stump. And during every single one of those scopes, we have to take at least 32 random 4-quadrant biopsies every 10 centimeters. The entire goal here is to find dysplasia. If we find high-grade dysplasia, that is an absolute indication to go back and remove the rectum.
A very thorough plan. Okay, one last question. The pathology report from her emergency colectomy comes back, and besides the severe colitis, it shows an unexpected invasive adenocarcinoma in the ascending colon. How does this finding change your long-term management and your plans for her definitive surgery? Well, this is a game-changing finding. It completely pivots our management from IBD to formal cancer principles. A restorative J-pouch is now off the table. The patient needs a full cancer staging workup. The definitive surgery now becomes a completion proctectomy to remove all the at-risk tissue, but it must also include a formal oncologic lymph node dissection of the mesentery we left behind. And of course, her care has to be discussed in a multidisciplinary tumor board. The scenario is a brilliant example of why we send every surgical specimen for detailed histology, because an unexpected finding can completely change a patient's entire future. Thank you, candidate. That concludes the examination. And that also concludes our simulated oral exam. This format really shows the kind of structured thinking needed for these complex patients. And that final question leaves us with a critical thought. In emergency surgery, you always have to be prepared for the one unexpected finding that can change everything.